We're live.
All right. Well, welcome. Welcome to our advisory council members. Welcome to those watching on the HPC's live stream. I am very pleased to welcome you to the HPC's first advisory council meeting of 2024. My name is Colleen Elstermeyer. I'm the Deputy Executive Director of the Health Policy Commission. I have been on maternity leave for quite a while, so I haven't seen many of you since I had my second child. I am happy to be back at it and happy to be with you all today. We have a really great, timely two-part agenda today. We are going to be talking about access challenges across the incredibly strained healthcare system. I saw a New York Times news alert as I was signing on to this about the sustained crisis levels in nursing homes across the country. And the second item we're talking about is the affordability of healthcare, specifically coming to you about developing a new affordability index to modernize our now over a decade old healthcare cost growth benchmark, and how do we measure and track affordability indicators as part of that benchmark process. So we are expecting an exciting discussion on all the hot topics and issues and challenges facing you all, facing our healthcare system today. So we really, really genuinely appreciate you being here. I do want to recognize first the chair of the Health Policy Commission, Chair Deb DeVoe, who is joining us today. Welcome, Madam Chair. Thank you for being here. And before we get into the discussion, I do have one bit of business. Speaking of the benchmark, this is our advisory council membership. We flip past that slide, but I do want to recognize we have a number of designees today. So it would be helpful if you do, once you comment, just announce your organization. Very helpful to us. And on the next slide, this is our slate of meetings for the year. So we meet every quarter, June, September, and December. Mark your calendars if you haven't already. Much appreciated. All right, the bit of business is our annual benchmark hearing is just 2 weeks away, March 14th, Gardner Auditorium, Massachusetts State House. As you all know, this is a hearing to solicit and receive testimony on setting the healthcare cost growth benchmark for calendar year 2025. So we are excited to be once again co-hosting this hearing with the Joint Committee on Healthcare Financing, led by Chairs Friedman and Lawn. You all know the healthcare cost growth benchmark is a fundamental mechanism for our cost containment efforts at the HPC, and this hearing really does provide a critical opportunity for public engagement in this process. So any of your organizations, any members of the public that wish to testify at the hearing, we ask you to pre-register in advance by emailing Ash Conter on our team. Her email's right there, ashley.conter@mass.gov. She'll get you signed up on the list. And we'd really appreciate that. We also welcome written testimony via mail, which many of you do, via mail or email. The deadline for that is a bit later, that Friday, March 15th. After this hearing process, once we've completed the hearing, we've received the testimony, we've analyzed everything, the benchmark for 2025 will be set by the HPC's Board of Commissioners at its next meeting on April 11th. Just a reminder, the default rate for 2025 continues to be 3.6%, equal to PGSP. That was recently set by the state, and the board can determine an adjustment to that, or any reasonably warranted adjustment, either up or down. They can set it to any amount. So that's where we're at with the benchmark, and we hope many of you will sign up to testify. All right, I will now turn it over to our Executive Director, David Seltz, to kick us off on our first agenda item. Thanks, David.
Thank you, Colleen. Thank you, members of the HPC Advisory Council. Thank you for being here and participating in today's conversation. And thank you, Chair DeVoe, for also being here to participate in today's conversation. We really picked these two topics today, reflecting on just the current conversations that everyone is having. And the access challenges and the affordability challenges are just so top of mind to so many stakeholders across this Commonwealth. And as I reflect on who is a part of this advisory council, it is just truly such a unique and special group of individuals that you all represent, truly reflecting so many different parts of the healthcare continuum, healthcare delivery, healthcare financing, patients, workers, and all different types of healthcare that I really felt like bringing these topics to this group would really help solicit some new insights and potentially some new solutions to some of these pretty significant challenges. So the themes for today are really around access and affordability. And we're going to start with the access conversation, because we really want to be able to understand from a provider, a payer, a frontline worker, a patient perspective, what it's like accessing and moving through our healthcare system at this particular moment. The issues of delays in care, ED boarding, and challenges discharging patients to post-acute settings has been, I think, widely reported in the press and is the day-to-day reality for so many on this call today. Also, the state has really taken a prime interest in this. The state has designated, I believe it's the entire state is at least at tier 3 of kind of a ranking system that was put in place during the pandemic to be able to identify capacity concerns. And tier 3 is a high risk tier. And this has spurred some action both from government as well as from different market participants. And I know recently Governor Healy and Secretary Walsh announced efforts along with many of the major health plans and with the hospital association around discharge planning and easing certain prior authorization on discharging out of the hospitals. And so that was, I think, a really important step taken by both the health plans and hospitals, as well as the leadership of the governor in identifying this as a major bottleneck. And what I hope to do today is to build on that, some of that momentum, and really solicit from all of you what you think are some of the contributing factors leading to these challenges. And I do think of this as a challenge that is not just in the hospital. This is really a whole system challenge. And I think it's important that we think of this as a whole system challenge, because it really is from the community into the hospitals and out of the hospitals. It's primary care and behavioral health care, all of these really important factors that are contributing to this current moment. And I really want to be able to hear from all of you, what your experience is today, and also hopefully identify some areas where we can work together, and whether those are policy solutions or collaborations between HPC and the marketplace, or even state government more broadly, where can we find some relief? So before I really open it up to hear from all of you, I wanted to start with presenting a few data slides. I always love to start with the data, and I think the data is really interesting and fascinating about what it's telling us about kind of patient flow throughout the system. So I have about 7 data slides, which I'll walk through, and then pause and really open it up. So the first data slide here is around total emergency department visits. Clearly, there has been a lot of reporting on backups in the emergency department. And when we look at the statistics and the data here, interestingly, we find that the rate of emergency department visits is actually still down from a pre-pandemic level. The blue line here is overall ED visits, minus 8% compared to January 2019. And then we subcategorize these ED visits into potentially avoidable visits in the gold line, also about 9% down. And this accounts for about 40% of all the ED visits, what we designate as potentially avoidable. And this means that visit, as we look at the claims data, potentially could have been treated in a non-emergency department setting, could have been treated in a primary care setting, or could have been treated if there had been an intervention earlier. And then finally, in the orange at the bottom is behavioral health designated ED visits. And so we see this trend still of lower overall ED visits. But as we see on the next slide, we also see that there is an increasing rate of people boarding in the emergency department. And so even though the overall numbers are lower than a pre-pandemic, what we're seeing is a steadily increasing share of patients who are in the emergency department for an excessive length of time. And what we designate that is really 12 hours or longer in the emergency department. Again, you can see the blue is overall ED visits that had more than 12 hours in the ED, rising from 6% in 2020 to over 10% in 2023, 4 percentage point increase there. And then the orange is the non-behavioral health, and then the gold is behavioral health ED visits. And you can see clearly that behavioral health ED visits are much, much more likely to board in the emergency department. 30% in 2020 experienced 12 hours or longer, and that has risen to 38% in the most recent year. So we're seeing a trend in longer times in the emergency department. And I note on the right-hand side here too, Chia has a statistic on treat and release times, and those increased by almost over an hour for all patients compared to a pre-pandemic baseline. So what else do we know about who is arriving in the ED and where they ultimately receive care? On this next slide, we tried to break this down in the data to try to understand who is coming to the emergency department, how, and ultimately what is their disposition. So what we found here is that of all ED visits, and we looked at Q3 of 2023, so this is pretty recent data, about 75% were walk-in patients into the emergency department, whether that's coming in on their own, driving in, taxi, Uber. Patients are walking in, and that represents a very large proportion of total ED visits. Only about a quarter are arriving via ambulance, that 23%. And then what do we know about what happens with those patients? Well, the vast majority, 75%, are discharged directly to home from the emergency department, and about 17% are admitted into the hospital. And you can see a few other things here: leaving against medical advice, transferred to another facility is smaller proportions of ED visits. And then when we look at the patients, that 17%, which represents about 111,000 visits that are admitted to the hospital, we can then further track those patients and say, where did they ultimately were discharged after their inpatient stay? And about half are discharged to home, 22% to home health, 15% to skilled nursing facility, and about 15% to other settings of care. And so this gives us a rough picture of kind of from the ED to discharge, how patients are flowing through this system. And what we know on the next slide, again here, we're looking at total hospital admissions in Massachusetts. And similar to ED visits, we do find that the total rate, the number of hospital admissions is down compared to the pre-pandemic baseline, minus 8% in terms of total admissions. And you can see again here broken down by some different categories. Admissions from the ED down 4%, maternity not pretty stable. But importantly, and I think important for hospitals, scheduled admissions are down 17% compared to a pre-pandemic baseline. And these scheduled admissions often may take the form of certain types of inpatient surgeries. Often these scheduled admissions are important revenue streams for hospitals. And so we do see a pretty significant lowering of these scheduled admissions. And I suspect some of that is moving to an outpatient setting, some of those surgeries and procedures. But even as, again, we see that the overall rate of hospital admissions is down compared to pre-pandemic, on the next slide, we find that the length of stay, however, has increased. And so the patients are staying longer in the hospital. And this, the average length of stay for all patients is increased by roughly half a day. That doesn't sound like much on its own, but when you multiply that by all of those patients, that is a very significant change in kind of how patients are flowing through the system and the inpatient capacity to take care of these patients. And here we're breaking it down also in terms of where the patients are ultimately being discharged to. And I think this is suggestive of a real challenge in discharge, because we see that the patients who are routine, this means kind of discharged to home or routine discharge, their length of stay has been pretty constant, 3.4 to 3.6 over this period of time. But when we look at the patients who are being discharged to skilled nursing facilities, we see a much bigger increase. And for home health, also an increase. So to me, this suggests that the increasing length of stay, it may be connected to an inability to discharge patients in a timely way to either home health or to skilled nursing facility. And the next slide here, I think, underlies why there may be this continued challenge in moving patients into these post-acute acute settings. This slide is looking at employment by different sectors of the healthcare system. And we're comparing it to basically a baseline of Q1 of 2019. And each of these lines show the change in employment for these different care settings or sectors. And so, for example, you can see significant drops in employment across all of these sectors in Q2 of 2020, and then a rebound for many of these sectors, beginning in 2021, 2022. And you can see, for example, outpatient is that kind of orange. We actually see that employment in the outpatient care settings has increased since that pre-pandemic baseline. We can see for general medical and surgical hospitals, that's the gold, has kind of rebounded to a little bit above a pre-pandemic baseline. But then we can see those sectors where there has not been that rebound and there has not been that recovery. And so psychiatric and substance use disorder hospitals, employment down 3.6%. Home healthcare services, employment down 12.5%. And most strikingly, of course, in nursing care facilities and skilled nursing facilities, total employment down still 23% below a pre-pandemic baseline. And I would note we looked at some national data too to see how we compare kind of on some of these trends nationally. And while there is a very similar pattern nationally, we did actually find that our continued decrease in employment in the nursing facility space appears to be a larger decrease than what we see nationally. The numbers nationally were more like in the range of minus 10% by the time we got to quarter two of 2023. Here in Massachusetts, minus 23%. Two more slides, and then I know there's already been a number of questions in the comments, which I want to get to. But another factor which will tie to our second agenda item later today that is also contributing to some of these access challenges is an affordability challenge. We know that many Massachusetts adults are reporting that they are not getting the care that they need due to the cost of care and are actively avoiding needed primary care, dental care, being able to fill prescriptions because of their concerns around the cost of care. And so this can lead to an exacerbation of health conditions. It can also lead to these patients who reported not getting the care they needed due to cost of care are more likely to end up in an emergency department for a potentially avoidable visit. And so there's an affordability part of this too that is impacting patients' behavior and potentially not getting the care that they need in the community as opposed to ending up in an emergency department. So the final slide here, which I will land on and will hold up while we open this up to conversation, is trying to kind of put all of these different pieces together and identifying all of the different places where delays in care are contributing to potentially avoidable emergency department use, that there is boarding in the emergency department, especially for behavioral health patients who may be awaiting, an appropriate care setting. We have increased length of stay in the inpatient setting, which again appears to us to be tied towards delays in discharge to post-acute home health and long-term care. And this kind of graphic really, I think we tried to think of the entire picture here of how patients are challenged moving through this system, and how our healthcare system is challenged being able to appropriately care for patients in the right settings and in a timely and effective way. And the way that our workforce challenges interplay with each one of these different bottlenecks and settings. And so I'm going to stop here, and at this point, going to open it up because I'd want to hear both kind of reactions to some of this data and information, but also to hear, how much of this is consistent with what you all are experiencing on a day-to-day basis. And again, hopefully steer us into a conversation of what can we do about this and where are some potential solutions. So I know there was a number of questions in the comments, which I will get to, but to kick us off, I wondered, Tara, if I could turn to you to help lead this conversation and to get your perspective and experience in this current moment.
Well, thank you, David, and thank you for that outstanding presentation as always. And for those of you who don't know me, I'm Tara from Mass Senior Care, and we represent the long-term care facilities in the Commonwealth. And David, I think you hit the nail on the head with identifying workforce as a key concern and barrier, but there are others. But before I get into the others, I can't not talk about workforce, because on the one hand, it is true that we are still in an acute crisis when it comes to workforce. But thanks to the collaboration of so many in your and HPC's work in documenting the workforce crisis, the legislature's investment, we are seeing hopeful improvement, meaning we went from a 23% vacancy rate to now a 16% vacancy rate. We've increased staff wages by 35%, and that's a phenomenal result. And then we've also reduced, still very high, but reduced our use of temporary nursing. And this is all available publicly. It's PBJ data that nursing facilities file quarterly with CMS. So there's good news relative to the accomplishments we're making in workforce. And what that means is that now we're able to say yes more often, not always, but yes to families and to hospital case managers that are discharging to our setting. We now have 90% of licensed beds occupied in Massachusetts nursing facilities. And I think what has allowed that to happen is not just the staffing that we've been able to increase and improve. And I'm very concerned about the fiscal picture in the state and us taking our foot off that gas, because if we take that foot off that gas, I'm very concerned that we will not be able to make these investments in sustainability. Because the truth is, we have an aging population, and it's 20% increase in 85 plus, which are those that need our services. So the other area that I think has been positive is, and you mentioned it, David, is the great collaboration and leadership of the secretary to bring providers and systems together during this heightened concern of throughput to waive prior authorization. I didn't realize what a big deal that is for our setting until I saw the data and numbers. And it has had a huge impact in making sure that patients can move quickly through the continuum and back home. So prior authorization, continued work on that with our partners at the plans would be really helpful. The other is specialized populations. These aren't the same patients that we have been taking care of for decades. These are medically complex or behaviorally complex patients. And so I think it's important that we continue to recognize that in our payment methodology. Again, Medicaid, Mass Health has done a great job of having special add-ons for patients that have complex medical needs, behavioral needs, as well as bariatric, and we've done a lot on dialysis. We have instituted in record speed dialysis dens across the Commonwealth to ease what we saw was a transportation barrier to making sure that we could admit these patients, ensure that they have their dialysis treatment, but we were having severe challenges with accessing dialysis treatment because of transportation. So that's an example of how we've worked together to solve. The other area that nursing facilities have identified is now that the national public health emergency is over, the 3-day rule. So in order for Medicare to pay for skilled nursing facility care, a patient has to be admitted, not in observations, admitted for 3 days in order to receive that benefit. We are seeing increasingly, for whatever reason, patients aren't being admitted. They're being on OBS and then trying to send the patient to skilled nursing facility, but they don't have a way to pay unless they pay privately. And that's not a burden that many families want to take on. So you may remember, David, that in Chapter 224, we had a section to look at a statewide waiver, ask CMS for a statewide waiver to the 3-day rule. That might be a way that we could work together to see if there's any opportunity to look more closely and ensure that people can move through the healthcare continuum as quickly as possible to get them home. And then finally, and I appreciate you very much raising the issue of avoidable ED visits, because that is at the crux, I think, of this issue. And for us, we see if we were able to have more meaningful conversations with patients in our setting, but also upstream as they're in their physician, like primary care office, or even in the hospital sometimes, about hospice and end-of-life care, we're seeing that we're having a lot of patients sent to the ED because families often aren't sort of ready to accept the condition of their loved one, for example. So we did a survey of members and found that 75% of end-of-life discussions actually happen in the nursing facility. That's a high number. And we wish we could think about how we can collaborate. And I know MHA is doing a lot of work on this also. It'd be great to get physicians and others involved in making sure that we're having those conversations. So that's an example of ways, again, that we could collaborate. So workforce, prior authorization is really helpful. All that we're doing on incentivizing and payment for specialized populations. And yeah, if we could hit that home run for the 3-day waiver would be great. Okay, David? Thank you.
Thank you. And I'm so appreciative that you started with some positives and some areas where we're making progress. I think it's always important, even in the face of these significant challenges, to acknowledge when there has been some good work. I think I heard, what was the average wage increase? 35%. 35%. A reduction in some of the vacancy counts, and
pool
again,
usage, temporary nursing reduction,
reduce temporary nursing. And one question I do want to be able to get to others here, but what more needs to happen? Is this a sustained? Do we just need to sustain some of these efforts and make sure that they continue to be funded and supported? The kind of innovation around specialized populations, is there more there? What are your priorities as you kind of think ahead to both the legislative session and budget and other priorities right now?
So I think on the workforce, it is absolutely about a quality job and wages. And so investing and then growing our own staff. So there's a lot of work, again, being done on career ladder and investment in career ladder and pipeline, and even sort of how do we tap into migrant workers. So it's still growing. That workforce is a top priority of ours, and then making sure that we can pay them. So then in regards to just sort of what HPC does a lot of work in thinking about, it absolutely is taking a deeper dive into prior authorization and just sort of those regulatory barriers or payment barriers that make it harder for patients to access care in a timely way. And so, yeah, PA and 3-day and specialized populations, I would say. I would add, but not for right now, is just making sure that we also have a way to streamline Medicaid eligibility process. That's a huge delay for our discharge planners and hospitals, as well as in nursing facilities.
That's great. Thank you. Thank you so much. And I did want to acknowledge one of the comments that we received around, understanding what are the number of beds that we have available in our healthcare system in a pre-pandemic, throughout the pandemic, and post-pandemic. And we do have some of that data, and you always want to look at not just licensed beds, of course, but those beds that can be staffed and stood up. And we know, I think, that there has been certainly in certain areas of the state. I'm thinking of southeastern Massachusetts, where Norwood was closed. Brockton, has gone through its issues. That there have been changes in just the overall inpatient capacity due to some of these exigent circumstances, and also the staffing challenges that we know continue to play a role in being able to staff the capacity that we currently have. And I think that also may apply in the behavioral health space, where we do have some capacity and we have some inpatient psychiatric beds, but do we have the staff to actually staff them so that we can get patients into these different settings? And so, Donna, I'd love to turn it over to you to talk a little bit about what you're seeing in the behavioral health space, and kind of how patients are flowing through that, and what some of the workforce challenges you're observing.
So thank you very much. And I appreciate the upbeat note that on which the earlier comments started. I want to acknowledge that because of unprecedented efforts in the administration in the last few years to increase rates for behavioral health services, that there are salary improvements, also implementing services like urgent care, which have provided a bump up in rates. That rate relief has had a direct impact on staffing, but there are still high rates of licensed and direct care vacancies. Even though the vacancy rate looks like it's moderated quite a bit to 3+% in behavioral health, I noted in the chat that a lot of the vacancies remain in licensed personnel, and in inpatient units, this plays out where you may be able to staff direct care, but you can't hire a physician, and you're required to have physicians on the staff to operate an inpatient unit, or certain levels of clinical nurse specialists. So those problems, those challenges remain. And consequently, we have licensed beds in our general and private psychiatric hospitals that are empty, right, because they can't be staffed. Yeah. But the more important problem for flow is in the community. Our inability to have sufficient amounts of affordable housing, and housing that is linked effectively to the supportive services that people need to be outside of emergency rooms and outside of hospitals. It continues to plague the people who depend on these care systems and those who are operating and advocating for them. And as a consequence, if the general and private psych hospitals are sitting on a number of patients, some of whom have lengths of stay that should have been for days or a couple of weeks, exceeding a year in the worst cases, because there are no community-based services available to house and support them. And there is no access right now to the Department of Mental Health's continuing care beds. DMH has experienced a radical shift in admissions to continuing care beds, with the courts filling those beds with forensic patients, to the point where there are literally a handful of civil admissions to those beds in the last year. And by the way, many of the patients coming in under forensic status are people who've prior been in the civil system, but the frustration with the civil system right now is leading a lot of people to file petitions in courts and try to basically work around the civil commitment system and get people in under forensic status through the courts. This department has tried to address this by expanding capacity for continuing care beds, but they are now on their third effort at procuring additional beds. There's been a challenge in the behavioral health inpatient care providing community to bidding on these opportunities. In some cases, providers don't feel they have the competence to serve continuing care patients. In other cases, they can't identify the operating space, but finally, the rate has been a challenge. So the department has, in each successive effort to bid this, increase the rate. There's a hope that this time there will be some bidders who respond to this and therefore could add some capacity for people to be transferred there. But I can't underscore enough that, building our community system in a way where we have the competency to tie housing to clinical and support services is the most important solution to this problem. The other important solution, which is in play and having some impact at the front door, is getting upstream of life-threatening emergencies or the other crises that take people to emergency rooms and beginning to see people earlier, implementing urgent care and mobile crisis intervention that is outside of the hospital setting, keeping people from kind of moving to emergency rooms to begin with. So investments in both these ends of the spectrum, if you will, are critical to solving the problem at the core we're displaying here of emergency department and inpatient flow.
Thank you so much. I really appreciate you laying out kind of the need for the community investment here. And we spend a lot of time and rightfully thinking about, our general and psych inpatient capacity and where that is and where we have some but can't actually put patients in. But we also really need to think about those upstream opportunities to intervene, being able to move people out of those inpatient settings back into a community and a supportive space. To me, it just your comments really speak to the interconnectedness and the interrelationship between all of these different settings of care and how we do need to think holistically about where we make our investments and where we continue to have support. What has been, one follow-up question, what has been your experience with the community behavioral health centers and the increased prioritization by the state in building out that system capacity?
I think that since the implementation on January 3rd of 2023 of the roadmap and the community behavioral establishing or designating the 25 community behavioral health centers, establishing the behavioral health helpline, and establishing urgent care as a service in the array of services operated by the community behavioral health centers, we have seen a large increase in the number of cases flowing into the system for the first time at the outpatient level. We have seen an uptake in the use of urgent care, although it's not fully where it should be, because I think people still don't understand the change in the structure of the system and what is available to them. There was a lot of reticence at the beginning of this to over advertise, if you will, my words, not anyone else's, lest we fail to have enough staff hired up to respond. But in that reticence, we missed some opportunities to communicate what's now available to people. And I think we need another round of public awareness and communication about the services that they are providing. But the initial data coming out of the behavioral health helpline, of the community behavioral health centers, in terms of the increasing use of urgent care, the decreasing use of emergency room care, the role that mobile crisis intervention, which is now pretty much fully staffed for both kids and adults, has increasingly played. These are important things to be looking at. And I think those numbers and alternatives can build with as they become even more fully staffed, and as people get used to a different way of dealing with an emerging crisis or an actual crisis.
That's great to hear. We at the HPC actually have a role to play in doing a little bit of an evaluation on the hotline in particular, and so that's something we'll be working on later this year, and I'll be sure to reach out to you as we begin that work.
Certainly.
Would love to hear from you, Colin, and then Ron, you're on deck.
Thank you so much. I'll try and be brief. I know we've got a lot to get through and a lot of people waiting to speak. In the spirit of including some good news, I mentioned we're looking at that sort of higher length of ER stay for folks with BH diagnoses. The need for peer respites. And I will say, I remember when there was only one in the state, and now there are 4. So that is definitely a step in the right direction. However, those 4, I think, only have about 20 total beds. So the need for further investment in that space, it's not only cheaper than BH, than the inpatient BH, let alone sitting around in the hospital room, but for a lot of people, it provides better outcomes. So that would be one piece. The other thing I will say in terms of the workforce, and particularly the decline in the home care workforce, and we're really concerned the governor's budget calls for $100 million in cuts to the PCA program, and in particular by setting an eligibility floor where those with less than 10 hours a week of assessed ADL need would not be eligible, regardless of their level of IADL need, which we think this will particularly hurt people with intellectual and developmental disabilities, whose IADL need is often higher than their ADL need. And we think that this will we've been assured, oh, well, if those people are no longer eligible, but then they can go into home health instead or adult foster care. But given that there are already waiting lists and there's already workforce challenges in home health, we're really skeptical. And we're really concerned that this is going to lead either to more unpaid care being provided by families, which is a drag on the overall economy, or more people being pushed into facilities, which I don't think anybody wants. So for all those reasons, I think that's, even though it's, it seems like a cost savings in the short term, I think it might have really negative consequences.
Thank you, Colin. Absolutely something to keep track of. Ron, how are you?
Fine. How are you doing?
I'm good.
So I know you mentioned some of the natural and physical disasters that we've had on the South Shore, which have affected capacity. But I think one way to look at this data is to look at the regional adequacy or capacity, because when you look at narrow networks and so forth, it's really important to see that the services are available. And I think if you break it down and look at the demographics of some of these areas, the income of the people in the area determines how many urgent care centers open and some of the capacity that's available. So there's always a direct correlation, or between, I say indirect correlation, between facilities and income and wealth. So I think that it would be interesting to look at this from a regional point of view, looking at subpopulations of patients to see if it's really worse among some segments, which I believe it is.
Yeah, that's a great suggestion, Ron, and we can absolutely do this and cut it by different region. There were some questions around some of the data, questions around whether we can look at race and ethnicity, community income, where we may know a little bit more about the diagnoses and the disposition of different patients. The data set that we're using for this, which is the emergency department discharge database, is really quite robust and does allow for a lot of those different types of unique analyses. And so we can look at this again by a number of different variables and factors. And Ron, to your point, I think one of our recommendations in our cost trends reports this year was around bolstering the state's ability to do these types of focused assessments of the supply and distribution of services and whether those align with patient and community need. And that is an area where we have recommended that could be really beneficial to informing a lot of these conversations if we were to have more of that kind of focused information available to policymakers and to the public. Liz, would love to hear from you.
Thanks, David. So as the insurer representative, I'd be remiss if I didn't talk about the impact of prior authorization on patient flow. I can appreciate the perception that eliminating prior auth has eliminated a barrier to patients moving through the system, but I think we have some real concerns that that perception isn't borne out in the data. So as David mentioned at the top of the meeting, MAP member plans have stepped up to waive prior authorization for transitions from acute care hospitals to post-acute care through March through to April. And that's been in place since January. And that's not the first time that we've done this. We've taken similar steps during the same time period, January to April in 2023, 2022, 2021. And looking at the data from the 2023 experience, I think we have some real concerns about what happens when that check of prior authorization is absent. So during the 90-day waiver in 2023, the number of patients awaiting discharge to skilled nursing facilities decreased by only 3%, while the number of patients awaiting discharge to long-term acute care hospitals or institutional rehab facilities actually increased by about 52%, which really indicated that the waiver of prior authorization can't address the system-wide capacity challenges that we're facing. And I think that raises concerns around care coordination, patients being transferred or placed to in inappropriate or ill-equipped post-acute care facilities. So our member plans tracked their members closely during that time period, and we found that waiving prior authorization actually increased overall admissions to post-acute care facilities in place of home health services by about 14%. Increased out-of-network care by about 50%, and resulted in large numbers of members identified as not meeting clinical criteria to be admitted to a post-acute care facility, but who were inappropriately placed due to the waiver. And I think each of these factors have an impact on healthcare costs and quality for patients and consumers. For members with really complex medical and behavioral health needs, inappropriate placement can prolong inpatient care or exacerbate existing conditions, or bring them back to the emergency room, and then they're stuck in the system again. I wanted to kind of lift up some of the really phenomenal work that's being led by the state for expedited psychiatric inpatient admissions, and point to that as perhaps a model for consideration for addressing some of the challenges we're facing in post-acute care placement. So this work has really been championed by the Hospital Association and the state, and they've pulled together a really amazing collaborative work group that meets monthly every other month to expand the functionality to identify bed availability, folks who are awaiting placement, and they have adopted the use of this centralized platform, point-click care, that's used for admission, discharge, and transfer data. And so I just point to the work that is being done in that space as an opportunity for us to think about ways to collaborate while preserving important tools to contain costs and ensure that patients are getting the right care in the right place in the right time, but also being mindful of the challenges that we're facing with finding placement for folks. So pointing to that as a potential opportunity for us to collaborate.
Thank you very much, Liz, and I'm glad you brought up and highlighted the expedited placement process. And I think on the issue of prior authorization, I think I would be really interested in seeing some of that data that your member plans collected, and some of the outcomes that you observed. I continue to think that this, is not the solution, but for a really multifactorial challenge, but there may continue to be places where reducing some of the administrative hurdles for patients may result in more expedited and appropriate care. And so just an opportunity for us to continue to think about where those are, balancing the different competing needs and interests that you mentioned quite eloquently, Liz. Steve, I want to maybe put you on the spot a little bit here too. I of course, like many of us on this call, get the MHA Monday report. This has been an issue that you have been highlighting in terms of some of the capacity and throughput challenges. You have been working with the health plans and working with MAP and Blue Cross Blue Shield to identify different solutions. I'm wondering if you could just share a little bit about your kind of current perspective on how things are hopefully improving, and or what do we need to do to continue to build that momentum for improvement.
Thanks, David, and thanks to the team for, as always, helpful information. I think two things can be true at the same time. I think there can be a lot of really smart, really well-meaning people doing really good work, but us still failing our patients, our workers, and our hospital and provider system. And I think that's where we are. The reality is there are some good things that have happened, and some good collaboration that continues. But again, I think I said this at the last meeting because we have some of the best policy minds in the Commonwealth on this call. And so what sometimes we're void of is the experience of those patients and those workers, and the management that's trying to provide resources to be able to provide care. And we're still in a perfect storm, and Amy knows this well with the work that she does on a daily basis. When we look at this through the eyes of the patient, it's not a great situation. And as much as we message not to utilize the ED unless it's absolutely necessary, that is often people's only point of entry. So they're in the emergency department, and then they're waiting either to be discharged or admitted. And because we have 1,500 people on a daily basis that are stuck in hospitals waiting to go someplace, there's an inability to admit into med surg or into another unit. And it's a constant jigsaw puzzle that the teams are facing to try to meet the demands of the patient. And the one thing that remains constant is that they treat everybody that walks through the door, regardless of their ability to pay, regardless of insurance, regardless of geography, regardless of income. And they're doing it with fewer staff and fewer beds. And we have not moved on from the crisis. And so when we think about some of these solutions, we're thinking about them as if the crisis is over. But talk to Julie, talk to Commissioner Foley. They know the crisis is not over. They know their workers are still facing the same challenges that they have for the last 4 years and oftentimes before. So with more than 20,000 vacancies in our workforce that continue, with people waiting and with fragile finances, as the CHIA report just showed, no hospital is making money. We are still a system that is on the brink, and that as an industry, we have not recovered. And so we should apply the same principles of collaboration and of flexibility that we did to get through the darkest days of COVID to try to recover and see if we can put this system on some secure and stable footing for the patients that we serve. And the challenges of a large hospital system that is in distress only make it all the more uncomfortable. And as Ron talked about, when you have a flood and then a fire and then an overnight closure of a large primary practice in Compass, you have a whole region down the entire Route 24 corridor, from South Shore Hospital down to Sturdy and on to South Coast, that are railing from those demands and those pressures. And so we are not doing the job that we could be doing for the patients that we serve. And Liz is an incredible partner, as is the team at MAP and the team at Blue Cross and our local nonprofit providers that we're blessed to have in the Commonwealth. But the reality is there's a whole bunch of tools. Some of the data on that prior auth is actually because there may not have been a bed at the appropriate location that was staffed. So we were looking for any bed to move a patient through so we could admit a really sick person who had deferred care through COVID, who waits in the ED to be seen and then admitted. And I know, David, you've visited a number of EDs with your team, with your chair over the past 6 months, and you've seen the wait times and the challenges that our patients are experiencing and are facing. And so there's a lot of good work happening, a lot of collaboration from our providers, our payers, and certainly our workforce. But we are not out of this. And I think thinking as if we are beyond the crisis, and we can go back to our discussions around simple affordability and benchmarks and PIPs. I mean, let's institute a performance improvement plan for the whole Commonwealth. not for any one individual provider. And let's improve the way we deliver care in our Commonwealth. And let's do it by expanding the flexibilities that helped us through, by increasing our opportunity to build work through scholarships and tuition reimbursement, by focusing on the equity issues that the compact has highlighted as serious concerns throughout the Commonwealth, and by continuing to change the way we transform our delivery system through looking at hospital at home and telemedicine and the other technologies that are going to allow us to keep people out of the ED. So I apologize for my long-winded answer to your simple question of how we're doing, but that's how we're doing. And there are a lot of great people on this call that are working every day to improve it. But right now, it is not a report of progress, it's a report of survival. And our workers are in there every day doing what they do for the loved ones that they serve, that are our family and friends that present through the ED, and those workers come back and do it again and again and again. And it's a perfect storm of challenging wait times for patients that have deferred care and often don't have primary care, an exhausted workforce that have done everything they can to meet the demands of those patients, and an under-resourced management that's desperately trying to keep services open, and keep their beds staffed for the patients and communities they serve.
Thank you, Steve, and thank you for your leadership on this issue and for continuing to sound a note of urgency, and that we do need to continue to identify and work together on these issues. As you know, Steve, when the pandemic first hit, I was volunteered to help work with Secretary Sutters and the command center on identifying and managing capacity across the system. And systems did come together, and different organizations and stakeholders were able to find common ground for the benefit of the patients and for the workers of these systems. And I think your call to continue that needed effort and work and that whole system view is welcome. Before I turn to our second agenda item, I did want to just offer once again an opportunity, if anyone who hasn't spoken on this particular topic and wanted to share some perspectives, to please do so. Tara?
I'm sorry, David. And I
Yeah.
want to be clear that my enthusiasm in acknowledging some success does not mean that we are not still in an urgent crisis. But leaving that aside, because it still is very much a crisis, I wonder, and this might be rhetorical, but for you and for Chairperson DeVoe, what does success, and I've asked this question to some folks, what does success and progress look like in the eyes of HPC? Because I just wonder what at the end is it the ED boarding issue? Is it that we don't have the 1,500 people backed up? What does success look like? And again, maybe rhetorical, but I just wonder if you've all thought about that.
Chair DeVoe, do you have any initial thoughts on that? I'll put you on the hot spot.
I mean, I think it really would be in the eyes of the provider system in terms of being able to feel that we are now in a manageable situation for both staff and patients, which, I'm certainly hearing some progress today, but I'm not hearing anyone say we're back to our usual level of concern, which, in balance. I'm hearing that we're still at a very unusual and not well managed. So, is that what you're thinking, Tara? That we don't have a specific target in terms of number of patients that are sitting in the ED or waiting for placement, et cetera. I think it's more a subjective sense that we're not as out of kilter.
I think that's the perfect response that each of our sort of organizations should perhaps think about that and be able to articulate. Thank you for that. Thanks, David.
And thank you, Tara. I think that is a good question, and one that maybe we should all think about in terms of how we can track and measure that we're moving in the right direction, that things are improving. I'm really appreciative of everyone on this call for sharing your perspectives and sharing your concern about the current situation. We at the HPC, in addition to obviously, we love to be able to put together data, but I view our role as one of a convener and as a partner and as a sounding board on all of these issues. And I look forward to continuing to work with you and the chair through the board of the HPC, and the chair I know do as well. I'm going to move to our second agenda item, which is around affordability. But before I did that, I just did want to highlight a few of the policy recommendations that we made in last year's cost trends report that may be helpful in terms of thinking about the challenges that we've just discussed. So I'll just highlight some of these really quickly. One is around reducing administrative complexity. Again, if we can find opportunities to streamline or automate certain prior authorization or other standards practices across payers, this can provide relief to both patients and to providers. The second recommendation here, our recommendation number 7, was what I was speaking about a little bit earlier around the opportunity to enhance our oversight of both the supply and distribution of healthcare services in order for the state and policymakers to be able to be more proactive rather than reactive when there are changes in that supply and distribution, when there are closures, when there are changes in capacity within certain regions, that we have this analysis and the data to really be able to understand where do we need services for what patients, and how do we support and stabilize our healthcare system. We also have a sub-recommendation here around enhancing our oversight of certain for-profit and private equity investments in healthcare providers in Massachusetts. On the next slide, again, 2 other of our recommendations that I think speak to some of these challenges. We talked a lot about supporting and investing in our healthcare workforce. This was a big recommendation for us, and we had a workforce report last year where we made a number of different recommendations around investments and diversifying and expanding our healthcare workforce. And then finally, a recommendation around investments in primary and behavioral healthcare, especially in the community settings where we can get upstream with some of these patient needs and be able to care for patients and not have patients have to wait 6 months for a primary care visit, or not have an ability to get community behavioral health care to stabilize a crisis situation rather than having to go to an emergency department. So we hope to work with all of you and the legislature to continue to advance these policy recommendations in the months ahead. Great. So switching now topics to affordability. So on the next slide, as part of our policy recommendations last year, we did make a recommendation around updating and modernizing our overall benchmark framework to have a greater emphasis and priority on affordability and health equity. And we made a recommendation that we could complement what is our existing healthcare cost growth benchmark, which measures, the change in total spending on healthcare in Massachusetts, with additional measures that could track how the change in spending is actually impacting consumer and business affordability of healthcare. And we recommended and suggested that the state, HPC, and CHIA could work together to establish either an affordability index or a benchmark that would be measured annually and tracked annually, similar to the healthcare cost growth benchmark, in order to be able to guide our improvement efforts specifically around affordability and health equity. This slide is more focused on the affordability concept, and the affordability concept is what we wanted to talk with you a little bit more today. As we're beginning to think about how we can measure affordability or what metrics we might want to use for this endeavor, we really wanted to hear from this advisory council. We brought this up at the cost trends hearings. We asked each of the panels what they thought about having a complementary affordability and health equity benchmark I would say that there was almost universal agreement among all of the panels at the cost trends hearing that these are worthwhile policy goals to work on. And so we're taking it on to begin to put pen to paper on what an affordability benchmark may look like. So I'm going to turn it over to our Director of Research, David Auerbach, to talk a little bit about our kind of early thinking on this, show you some data about how different metrics may show the affordability burden for residents and businesses in Massachusetts, and how might an affordability index be used if it were to be put into law. So with that, David, I'll let you take control of the deck. And David, we're not hearing you.
Test.
Great.
Okay.
Go ahead.
Sorry about that. Thank you, David. And before I start, I just want to say we've been taking down all the questions in the chat, and some of those are things that our team might be able to help with, and we'll try to get back to the appropriate person on some of those data questions and comments. Thank you for those. Okay, so let's go to the next slide on the affordability topic. This is something that we discussed at the cost trends hearing, as David noted, and I'll just review this again. This was thinking about some of the principles that we would like to capture when we talk about an affordability index. And one of them is including not just the employee portion of the premium, but the employer portion as well, because these are dollars that are taken from the pool of compensation that employers pay. And to the extent that that amount grows year after year, that just means that is less money the employer is able to pay out as employee wages or other benefits. And this is really the highest chunk of healthcare spending, so we want to capture the full amount. We also would like to capture the deductible, not just the amount that people spend, but what is that full deductible amount? Because sometimes we know very well from our survey data that because patients or residents know they're facing that deductible, it sometimes causes them to avoid necessary care. And so that wouldn't show up in dollars not spent. So we want to capture the full deductible. And this is especially true. And then you have folks with chronic health conditions or giving birth who are spending that full deductible because that is just the price of getting the care that they need. We also thought it was important to not just look at the average experience, but folks who might have a higher than average premium, a higher than average deductible. And again, some of these are just related to who you're pooled with or what chronic conditions you might face. And all of these types of healthcare cost and cost burden should be considered in the context of what is your income? What are your resources available to spend? And that's really the key component of what affordability means. So given some of the feedback and some of these thoughts, we tried to capture some of these concepts in put some numbers to these concepts. And that's what we're doing on the next slide. Okay, so let me walk through this a bit. This is a table where we've constructed a few scenarios playing with these different concepts and parameters. And what we've done is we first started with the full Massachusetts population of those with employer-sponsored coverage. And again, this is a view of those with private coverage who are more directly impacted by healthcare costs than those, say, on Mass Health. And taking that population, we first found what is your income? And the 40th percentile represents if you lined everybody up by their family income, what is the level where 40% would have less income than this person and 60% would have higher income? So that's what that 40th percentile represents. And I'm showing the income for a family with employer-sponsored coverage, whether you're at that 40th percentile, it's about $90,000 a year, or the median income is about 120. And then some of the parameters that we use in this calculation, and you can see on the top line, what I'm doing in this calculation is taking the full premium, the full cost of that premium, both the employer and the employee part, adding what an average family is paying in co-insurance and co-payments, and then adding the full deductible and taking that as the numerator of this equation. And then on the bottom is your total compensation, including not just your income, but also what that employer is paying for your health insurance, that employer share, as you see in the third column, because that is compensation going to the employee, going to the family. So taking all these together, you can see on that top row, we have a family with income of 90,000. The average 2022 premium is 23,000. You see the employer portion, cost sharing averages a little over $1,000 that year, an average deductible of 3,600. And that then generates this index or this healthcare share of about 25%. And then we have several scenarios below that. If you consider somebody not with the average premium, but the premium at the 75th percentile, so where 1/4 of the population has a premium that's higher and 3/4 of a premium that's lower, that turns out to be $27,000. And that generates an index of 28.4%. And again, you can think of this as kind of a metric of the percent of your total resources available to you that is going to healthcare. And then, of course, those percentages are lower when you consider somebody at the median income, an income of about $120,000. So these are numbers that should have some intuition behind them, and it's also somewhat of an index. And I'll show a little more on the next slide of why I kind of like this 40th percentile income level. Let's have the next slide, please. I'm just showing those same figures, but in a bar chart. And okay, so we have this in a separate calculation behind this, but that 40th percentile family, these are folks whose, if you think of it in an FPL kind of way, those incomes are about generally around 300% of poverty towards maybe 350% of the poverty level. So you are, you're not eligible for a lot of subsidies, but you have employer-sponsored. About 70% of these families have employer-sponsored coverage. About 20% of such families at this income level have mass health, and about 7% are in the connector. So that gives you some context that these are mostly people getting insurance in the private market. And so another key point is all this data that I've been showing is taking statewide average premium figures. So to try to bring this to something with a measure of accountability, what you could imagine doing is you might, rather than taking statewide data, think payer by payer and apply this to their own premiums, their own premium distributions. Where is your 75th percentile? Where are your deductibles? And then you could just consider those levels against some, what is a benchmark? What is the level that we think is okay? What is a percentage that we think is maybe too high and unaffordable? So I'll pause there. That's a lot of information. I hope that was easy to follow. And are there any thoughts or questions around these concepts? Okay, great. I see a hand with Donna Mausch.
Thank you. Two quick comments and one accolade. So the accolade first. Thank you for putting this together. Your approach to capturing this is spot on. I would be remiss if I did not note an overarching challenge in the behavioral health space, which would not be reflected in these data, is how many people are forced out of network and actually out of any use of their insurance to get access to care, because 52% of our licensed psychiatrists, psychologists, social workers, et cetera, choose to practice outside of insurance-based systems. And while some give people information they need to bill their insurers out of network, a lot of times people are not successful or capture only a fraction of the costs. I would note that Kaiser Family Foundation has some data. The most recent I saw was a couple of years old, but just to illustrate for people with employer-based insurance, out-of-pocket costs of more than $2,000 a year were measured. For people with uncompleted suicides and self-injury, 58% incurred excess out-of-pocket costs, 48% of people with psychotic conditions, 38% of people with substance use conditions, closely behind that, 30+% of people with depression. So there's a lot that might not get captured here that I just want to make people aware of. Thank you.
No, thank you. I'm so glad you raised that point, because the spending here that we're talking about is really kind of run through the insurance system, right? And we know that there are costs that are health related, that are beyond that, and perhaps growing over time, and which only adds to these figures here if we're thinking about this in terms of kind of percent of total compensation that is going to healthcare related needs.
KFF used IBM market scan data, but so there's more out there that
Yeah, we'll look into
capture. I just want to say I appreciate your efforts to capture what is measurable, and want to note that those measurable things underrepresent the true picture in the behavioral health arena.
Yeah, absolutely. Thank you. Ron?
So I think this is interesting, but it's complicated in that I realize these are mostly private patients, but as you go down in income, the disease burden and prevalence of a lot of disorders goes up. So not only is it a higher burden, but the actual cost expenditure may be higher, and the access to care further complicates that. So that the facilities where you seek care may be the emergency room or another higher cost place, so that your actual expense for certain groups, reference to their income, will even be higher than this.
Yeah, I think that's right on, Ron. And I think it goes to a fundamental challenge of averages and medians that often mask really important differences in experiences and differences in variability underneath those averages. And so I think we're still thinking through what additional factors we may want to layer on here, while still trying to have something that is understandable and simple enough to be used, but that could appropriately reflect important nuances underneath the averages and percentiles. Any other initial thoughts and reactions? As I said at the beginning, this is absolutely still kind of a work in progress, and we wanted to kind of bring this early to you and to this group. And Liz, I see you've raised your hand. Please.
I have half-formed thoughts, so forgive me for not being eloquent with this. I think what I'm struggling with the development of the affordability index is how to marry the affordability index with the underlying costs of healthcare, and how the two intersect, and how that impacts the development of premiums and cost sharing for consumers. So that's one kind of general question. How are we marrying those two concepts? How does the affordability index intersect with maybe the cost growth benchmark, or discussions of those underlying drivers of healthcare costs? And then my other question, it might be silly. Massachusetts is such a high cost state, and the federal poverty level is a national index. So I'm wondering how we're considering the percentages here in Massachusetts. If it's 30% of your compensation in Massachusetts, is there a difference that it's 30% of your compensation in Massachusetts, but in another state it might be a smaller percentage because of the lower cost of living, et cetera? Apologies, this isn't a fully formed thought, but I'm just thinking, what's the impact of how costly it is here in Massachusetts on thinking about healthcare affordability in general?
Great questions and thoughts. And I do think that to your first question, I see this as living alongside of the healthcare cost growth benchmark, which really is around understanding those underlying drivers of spending, and where we continue to make recommendations on being able to moderate the growth in healthcare spending. We've made recommendations on pricing, on pharmaceuticals. And so I think this is another lens to be able to understand if we're doing work on addressing the underlying drivers of healthcare costs, is that actually translating to relief in terms of what consumers and businesses face? And I think that how we create that linkage and how we measure that, I think very much still open to discussion here. But I don't think that this can stand alone, Liz. I think this has to sit alongside our continued efforts to get at what is actually driving healthcare spending and in turn driving healthcare premiums, and in turn driving businesses to increase deductibles and to put larger cost sharing burdens onto employees.
I just,
yeah, go ahead, Liz.
sorry, just, I worry that if they're not continuously paired together, the perception becomes that healthcare affordability is just about the cost of your premium when you include the deductibles and cost sharing, et cetera. And health plans alone can't solve the affordability crisis. You know, it's a multi-legged stool. That's certainly a message that HPC has hammered home on multiple occasions, but just want to reiterate it here. We can't do this ourselves. We really need every part of the healthcare sector to lean in on the recommendations of the HPCs.
Carlene, how are you?
I'm well, thank you, David. And Liz said her thoughts were unformed. Mine are not even, don't even merit unformed yet. They're amorphous. But I think I decided to comment when I heard you talk about and Liz ask about the need for looking at this beside the cost benchmarks. I think it is also essential to look at it beside whatever you are developing for the equity benchmarks. Yeah. I'm having trouble understanding how this will have real meaning, important meaning, if it isn't paired with the equity benchmarks. And it's because the inequities in health status by race, by geography, by disability status, by, a bunch of other things, impact the meaning of affordability as you're measuring it here so profoundly that if we can't accompany this with with data that is disaggregated by race and ethnicity and other markers of health status, I don't think it's really going to be importantly meaningful. Mm-hmm. But maybe others know more about what I just said or have better thoughts about that, and I'm wrong, which I would love to be. But
that was a very well-formed thought and perspective, and we in our recommendation really did talk about kind of three legs on this stool. One is updating our cost growth benchmark with some changes. The second was around this idea of an affordability index or benchmark. And then the third was the health equity index or benchmark. And we really did think of those three recommendations working together. And this presentation and our conversation today has been more focused on the affordability piece than the health equity piece. So I take your comment to heart in terms of how we think about putting these different puzzle pieces together, and that if we think about this more holistically, we may end up with something that is more meaningful and more impactful, kind of pulling together those different themes and thoughts. But Carlene, please redirect me if I have that wrong.
No. Can I just, I'm not correcting you. I'm just sort of leaning in on one of the things that I'm thinking. I'm worried that without having this placed right next to the health equity benchmarks, that we start to see something. The analogy that's coming into my head is about when we talk about how Massachusetts is the healthiest state, right? And by now, all of us know, yes, sure, it's great. We are the healthiest state, but there are pockets of inequity and we have to pay attention to those. And that is critical. I'm worried if we start with this, we think this looks bad. I actually think this isn't as bad as I thought. And I think it actually masks the worst of the affordability crisis that we're facing. And that's why I think it has to have that equity information beside it so that we are always analyzing it with the eye to where are the real pockets of not inaffordability, because this isn't as bad as I thought it was going to be.
Yeah. And Juan Lapera added in the chat, seconding your comments around keeping these linked. And when we talk about this in the report, I often use this kind of circular kind of graph indicating how these three concepts, cost containment, affordability, and health equity, are linked together. We have a few more minutes, so I do want to hear from both Erica and John before we close out on this topic. So Erica, how are you?
I'm good. Thank you, David. I'll be quick because Liz has made a lot of the points I wanted to make. But I think even if this affordability index is sort of linked with the cost growth benchmark and a health equity index, I still think there's a missing piece here. And, this bullet on this slide saying ultimately the index could be calculated separately for each payer to ensure accountability sort of goes to the idea that insurers are the ones that are being held accountable for affordability, when I think the HPC's own data has shown that there are other cost drivers. And even within the benchmark, there are missing sectors that are not being held accountable. And so as we're thinking about moving forward on affordability index, I do think we need to make sure all areas that sort of go to premiums are also being held accountable. And there is some way to ensure accountability on everyone, not just payers, and through the DOA rate process.
Thank you, Erica. And I think that is certainly our intent as we think about our recommendations as kind of a comprehensive piece that fits together, addressing all of those issues you just mentioned. John, you had also added in the comment, interest in trying to maybe look at this by different market segments and kind of employer segments. But please share your initial thoughts with us. And
well, thank you, David. I guess at the service, I like the concept, but you have to be careful. Just like the benchmark is flawed because it masks, the fact that Mass Health gets a certain level of increase each year. GIC gets another certain level. Big ERISA exempts get a certain level, but small businesses always get a far higher increase, and their employees than other purchasing groups. You got to make sure you got to put some real transparency on different levels and the inequities of small businesses and their employees. I can rest assured they are paying far more than that $24,000 average premium for a family policy. Our members are report $30,000 to $40,000 a year in a family policy. So you need to take the temperature and show the numbers depending on the type of consumer and where they're working, the size of them, and and also compare versus those that are getting taxpayer subsidies. A small business and their employees are paying far more and it's far less equitable and far less competitive. Those are the two big watchwords right now. We need to be focusing on equity and competitiveness, and no one is less equitable and less competitive than health insurance today for small businesses in the merged marketplace. You need to put a spotlight on that.
thank you, John. And I think you raised some important points here again around how do we appropriately capture the different experiences underneath these averages. And I think you hit the nail on the head in terms of what we're all working towards here, and it is the North Star of our governor: affordability, equity, and competitiveness. And I'm really grateful for all of your initial thoughts on this particular topic of both, and I'll say both the affordability index idea as well as a health equity index idea. If you are interested in helping to help us think through these concepts and how we might put these pieces together, I would very much welcome that. Please reach out to Colleen And we would look forward to engaging with you even outside of these regular quarterly meetings to help us think through how we can continue to move these concepts forward. So if you're interested in that, we would appreciate your help. And as always, thank you for your time and attention to this great conversation today. Chair DeVoe, any final words?
Really appreciated the discussion. Thanks so much to everyone. A lot to think about and take back.
Colleen, any final words?
No, look forward to seeing you all at our next official meeting, June 27th, but we'll be speaking to many of you before then. So Liz, did you have a final thought you wanted to leave us with?
I do, because
Yes,
I'm
thank
never sure how long it's going to be before you toss me out. My comments are never as eloquent as those of some of you who've been at this for lots longer, but I'm struck by Steve's comments earlier, Dr. Dunlap's, Matt's, especially John's. I want to encourage you, but someone said at the beginning that the finest minds in policy are in this group, and I would agree. And there is still a significant disconnect. I'm remembering the conversation we had around how well we thought telemedicine worked. And as someone who works not only in Springfield, across Hampden County, across the state and nationally on USDA stuff, it didn't work well from a community perspective. And when you break that down by zip codes and race, it got even worse. And I worry that you don't have a voice that's more articulate than mine that can help tell that story. This group looks a particular way and has a median education level that is not reflective of those who are not represented in so many of the numbers that you report, however you report them, as bars or pie charts, and I would just be remiss in my life mission if I didn't keep reminding you of that. And I trust that you're listening. I know a few of you, so I know that you're listening. All of you seem to be compassionately minded and focused. This is not reflective of the lived experience of either most patients that are in the third largest city in this Commonwealth and in many of the smaller cities. And it's not reflective of the frontline people who are doing everything they can tirelessly every day to be engaged in prevention work so we catch people before they go to the emergency rooms. So I just have to put in a plea for when you start to look at your makeup and who you're inviting in next, you've got to invite folks who can help balance out this work, because I trust that you want to get to that benchmark. And when you say the crisis isn't over, not only is it not over out west here in the hinterlands, it feels as bad as it did during COVID. Certainly, I don't see as many processions to the funeral home that's down the street from my house, or the segregated cemetery that mostly serves Black and Latinx community members. But our homelessness is increasing, our hunger is increasing, and the food-related disease is off the charts. And you know this better than I do, especially those of you who are centered in healthcare. So yeah, that's all I wanted to say.
Thank you so much. An incredibly important note to leave us on. Appreciate you, Liz. And appreciate all of you. Thank you so much. And we'll speak to you soon. Thank you.
Bye.
Bye.